Hello, my name is Dominic Malika, and the disorder of the integumentary system that I want to look at today is going to be melanoma. So before you can understand melanoma and its effects, you first have to understand the anatomy, where it starts out, and this would be the epidermis. So over here we have a histological slide of thick or hairless skin, which is primarily found on the feet and the hands. And melanoma can happen here. It's pretty rare. Here we have the stratum corneum, the stratum granulosum, stratum spinosum, and this is where melanoma first starts, is in the stratum basale, which is where melanocytes reside. Over here we have a graphical representation of the melanocyte, and you can definitely see those arms reaching out to deposit the melanin in the more superficial layers of the epidermis. So just a few facts about melanoma. Um, it's pretty prevalent in temperate countries with a lot of sunlight. Uh, a lot of these countries have more fair populations, fair meaning lighter skin. About 70,000 new cases in the US each year. It's the most deadly form of skin cancer. Stage 1 has about a 90% survival rate, but stage 4, that drops all the way down to the mid 20s. It is the main cause of death in women aged 25 to 30, which did surprise me, although this could be due to tanning habits. Now we will look at the cause of melanoma, which happens to be UV radiation, which is a form of electromagnetic radiation from our sun. The main forms of UV that affect our skin are UVB and UVA. These are strong enough to penetrate into the epidermis and the dermis. When it penetrates, it can mutate the genome of cells. In melanoma, this mutation happens in melanocytes. 99% of the time, these mutations are fixed by cell repair machinery, but when it doesn't get fixed, that can cause rapid proliferation of cells, which leads to cancer. And some risk factors for melanoma, as mentioned before, countries where the populace has fairer skin, red hair, blonde hair, light-colored eyes, all of those are symptoms of not having a lot of melanin in the skin, which allows for more penetration of the UV into the lower levels of the epidermis and the more superficial layers of the dermis. So just a quick rundown on the pathophysiology of melanoma. About a quarter of melanomas start on moles, which are medically called nevi or nevus. This is areas of the skin where there's a higher concentration of melanocytes. So when a melanoma first starts off, it will be very superficial in the epidermis. As it grows, though, it can invade the dermis and tap into blood vessels and the lymphatic system. This is dangerous because these systems travel all across the body, of course. And here's the lymphatic system. We haven't learned about this in class, uh, but they all drain across the body, uh, and the migrating melanocytes can travel and basically set up shop in different parts of the body and cause tumors there as well. So these are 5 early symptoms of melanoma. The first one is asymmetry. Let me get my laser pointer out. As you can see here, we have benign characteristics of moles and malignant characteristics of melanoma. So for asymmetry, we can see that this is a pretty symmetrical circle here. This mole doesn't look quite so good. The two sides don't match. The second early symptom is border irregularity. Pretty good circle here of the mole. This one, very jagged, not very clear and defined edges. Number 3 is color variation. So this mole, it's about uniform in color. Uh, this mole is pretty crazy. It's very dark on one side and very pale on the other side. Fourth is diameter. You really can't see this on pictures, but anything smaller than about a quarter inch is usually benign, and anything larger than that is cause for concern. And lastly, evolving characteristics. So if the mole is getting bigger, if it's changing in color, if its borders are becoming uneven, that can be signs of melanoma. And as the cancer progresses and metastasizes, you can get more general symptoms such as fatigue, malaise, and weight loss. While the ABCDE method is recommended for patients, it's not quite enough to make a conclusive diagnosis of melanoma. Usually a dermatologist will use an instrument called a dermatoscope. I don't really know how to pronounce that. It is a instrument that basically magnifies and lights up an area of the skin and gets rid of a lot of glare, so the physician can really focus in on one part of the mole. Over here we have a histological slide. Now these are made when a biopsy is done. Um, I noted that it is very important for dermatologists to have an excellent understanding of what normal epidermis looks like. Otherwise, they won't be able to distinguish abnormalities, of course. So right here, this is melanoma. You can see a lot of darker cells, and those are going to be the melanocytes that are undergoing out of control proliferation. So there are treatments for melanoma after it is diagnosed. The most crude and common being just straight up excision of the mole. So usually surgeons, they cut out the mole, of course, but they also cut out an area about half an inch around, just for any parts of the tumor that are too small to the naked eye. They just want to be safe so it doesn't, so the patient doesn't come out of remission. More targeted approaches are done with immunotherapy and certain antivirals, which I thought was interesting. Not all patients respond to immunotherapy the same way, and sometimes stage 4, you really can't do anything about it because it hasn't spread to other parts of the body. So palliative care ensues in these scenarios. So when all of these other options have been exhausted, there is clinical trials going on with a procedure called adoptive cell therapy, which is basically when you take the white blood cells that are inside of the melanoma, you take them out of the patient, you treat them, I guess in a petri dish, and you reinfuse them back into the patient, and they fight the tumor more effectively that way. Now, a lot of the times before the reinfusion of the white blood cells, the patient is immunocompromised. Um, so this might not be recommended for patients at high risk of infection or who are already immunocompromised. And here are my sources. Thank you for listening.